And we're live in 5,
4, 3,
2,
1.
You got it? Okay. Hey, good morning, everyone. So we are going to have an exciting talk today, and we're going to discuss adult deformity, pediatric deformity. We're going to talk about MIS surgery for deformity and adolescent deformity. Usually kind of end of the year, we have our fellows kind of present. So today the Swedish fellows are going to present about the 3 different topics. So we'll start with pediatrics, we'll do adolescents, and then we'll do MIS and adult deformity, kind of how do you, obviously this is all surgical management. And then Dr. El Hushaimi is going to finish us off with maximally invasive adult deformity. So our first speaker is Dr. Mohsen Karimi. He is an orthopedic spine surgeon, actually practiced for many years in Tehran, and his practice focus was pediatric deformities, and he did some adolescents. So he has quite a bit of experience, and he's spending a year with us here at Swedish. Mohsen, come on.
Thank you so much. Good morning.
And Mohsen, why don't you tell everyone a little bit about your training? I think you spent some time in France, and then your practice in Tehran, and kind of what your practice was like. And I think just kind of the current status of doing pediatrics.
Yeah, so I graduated from Tehran University for my medical school and residency in orthopedic surgery, and then I went.
And where is that?
In Tehran. So
what's the name of it again?
At Tehran University.
Oh, okay.
Yeah.
Great.
And then I went to Paris, for a year of pediatric orthopedic surgery fellowship. So it mostly was like
with Kayvon Mazda,
Kayvon
right?
Mazda,
I knew
yeah.
Kayvon, yeah.
Yeah, so it was mostly
And
with
Brees, you guys did together?
Brees was like we were like co-fellow there. So it was mostly pediatric spine cases and adolescents. Yeah. So he was like Dr. Mazda was like doing more than half of scoliosis cases in France. So wow. A lot.
And neuromuscular stuff too, right?
Yeah, and neuromuscular stuff.
Okay, great.
For sure. So, and after that, I returned to Iran and working there, mostly focused on pediatric surgery, mostly focused on the spine, and got many referrals from other towns for those because we had like a very good PICU. So that was the main point. If you want to touch pediatric patient, you have to, have, very good colleagues in terms of post-op, complication, ICU for pediatric patients. This is very important. Otherwise, probably there is the same concept like adult, but less degenerative cases. Yeah, so actually, when we talk about deformity, so we can classify them as like adult, adult patient. They have like aging deformities, mostly because of degenerative arthritis and facet joint, instability causing deformity, and then adolescent idiopathic scoliosis, which usually it starts from after age 10, and then before age 10. So we have the an umbrella, term like early onset scoliosis, which includes infantile, juvenile, and other kind of scoliosis cases like neuromuscular, congenital, all stuff like that. So in terms of management for those patients, we call it like a delaying strategy. So we try to not touch surgically the patient before age 5, and then as far as we can, stop doing any kind of fusion before age 10. This is the main concept. So Most of the time, we start with observation and then bracing, casting, and halo traction. These are the main goals, the main principles for non-surgical treatment for those patients. So in terms of observation, we have a concept, we call it RVAD, which is very simple to calculate that at the apex of the deformity, we get the vertebrae, and then we draw two lines from the apex of the ribs beside, and then we calculate from these two angles the rib vertebral angle difference. If this is less than 20, or the phase of rib is phase 1, we can do conservative treatment. That means if there is no, covering of the rib over the apex, so that means there is no, overlap of the rib over the apex vertebra. We call it phase 1 rib. So if there are these, these criteria, we can do observation and observe the patient, mostly for infantile scoliosis. That means these are non-progressive, and then we can do like observation. If the RVAD is more than 20 or 25, so the risk of progression is very high, and then we have to choose a kind of next step or next step of treatment. So bracing, we can use bracing as well. So it's mostly stabilize the spine, not treating anything. Usually, if the curve is less than 50, we start with bracing. Most of the time, the bracing is like Milwaukee. We can use this at age like 5, 6 or less. But there is contraindication if there is normal skull cases. Osteogenesis imperfecta bracing can cause issue with the breathing and cause problem with that. And then for congenital cases, if you cannot put any pressure and correct it in congenital cases, that means bracing is not very helpful. So yeah, Milwaukee brace is the choice. We can use even in less than age of 6, and but should be like kind of modified Milwaukee. If the bracing is not successful, and then there's no indication for bracing, we can do EDF casting, which is a concept from French surgeons. So the goal is like buying time till we get to the a kind of age that we can do a surgery. So EDF is elongation, derotation, flexion. We use the straps to do traction and derotate the spine under the coxal frame, and then over the regular cast, we can use plastic like fiberglass cast, and then we can open windows to relieve pressure from the concave areas. But there are contraindication for riser casting as well. If there is like again neuromuscular scoliosis, thoracic insufficiency syndrome, we cannot put a cast because it's going to cause issue with breathing and even death to the patients. Okay, so what to do if we cannot do casting, we cannot do Milwaukee brace? What's the next step? Next step is like halo gravity traction. The thing is, we can use for ambulatory patients, not necessary to get the patient on the bed and do the traction. So you can use it on a walker and let the patient walk. So this is kind of the frame we use on the we mount everything on a walker, and the patient can walk with that kind of traction. We initiate with like 5-10 pounds. And then every day we increase that to 2-3 pounds, and then the goal is like 35 to 50% of the weight of the patient, and then at night we make it like half. So this is a patient of mine. She came to our clinic. She was like 4-year-old with severe infantile scoliosis and thoracic insufficiency syndrome. She contracted pneumonia and then ended up to tracheostomy. And then after that, they were not able to remove that tracheostomy because of severe scoliosis. Any idea about the treatment?
Mark, what do you think? I mean, obviously, this is not going to be corrected with halo traction, but maybe pre-op do halo traction.
Yeah.
What do you think, Mark?
I'd agree. You have to delay surgery as long as possible for her, and you can try some traction strategies initially, and see what you get.
Yeah. So among those options, I explained. So probably the best thing is halo traction. So I put her on halo traction like about 3 or 4 months, and then after that, her breathing got much better, and we were able to do like double growing rod. So the only option we had in Iran is like growing rod. We don't have access to the magic rod because it's very expensive. Rod is like $50,000. So we put her on double growing rod, and then start every 6 months distraction. So usually we put the screws in the bottom, screws or hook or hybrid thing at the top foundation, and we do like limited fusion at those spots, and then we start every 6 months distraction. So this is after 6 times rod lengthening. You see, we were able to remove the tracheostomy. And then the patient was doing good, so we continued this, and then we're gonna do the final fusion after age 10.
So there was no fusion done, it's just instrumentation?
Yeah, there is no fusion there.
Do you have to replace the screws? Do they loosen up?
Sometimes, so especially at the top foundation, there's like...
I mean, the fixation doesn't look like it would be that great.
Yeah, so because of the distraction, there are lots of force, and after a while, it kind of gets to plateau. You're gonna end up with the...
How do you position her on the table?
Yeah, prone position.
With halo?
No halo, no. Distraction is just with the rod.
Just inside too?
Inside to distraction, so that means we put the distraction for the
That's
rod.
amazing.
And lose those connectors and distract every time.
What system is that?
It is a pediatric Medtronic.
5.5 titanium?
Yeah.
And what size?
It's not 5, it's like 4.5, I guess.
Is it 4.5? Wow.
Yeah. It's a pediatric Medtronic, it's very tiny things. Yeah.
A very interesting case. I mean, the result looks great. I don't know, what were the numbers? I mean, that was pretty serious. That was like...
110.
Yeah, that looked like it was over 100.
Yeah.
It's amazing how in kids, how flexible some of these are.
So there was like traction X-ray as well. It was like not very flexible, but it's better than adult for sure.
And so at what age do you go in now? Do you have to wait until she's skeleton mature to do the fusion?
Usually, most of the time, so after age 10, 11, if the research sign is like, getting to, 3 at least, we can do the final fusion. And sometimes I had patient that I left those, construct there. I didn't do any final fusion because the patient was doing good, and then they reached to the final growth spurts, and then no sign of anything, so I left those instruments there.
Yeah, that's a beautiful result.
Yep.
Wow. And then how about, I mean, when you do the halo traction, I mean, how can you do it for a couple of years? That one patient you did.
It was 3 to 4 months to improve the breathing.
Oh, wow.
Yeah.
And they stay in the hospital or they go home?
No, at home. It's like on the walker when she walks, and then at night on her bed, we put the pulleys and everything.
That sounds horrible.
Yeah, it is, but there is no choice, for this case.
And then what's your thought on, there's these new braces that are coming out that are smart. What's your thought on these smart braces?
These are good not for this patient. I mean, she doesn't have any kind of good condition for her lungs. So if you would pressure for any kind of brace, regardless of being like very kind of So putting pressure on the trucks with bad, lungs, like thrust insufficiency syndrome, in this case, it's not helping and causing more pneumonia, and then you cannot, take up the tracheostomy.
Interesting. Thanks so much, Mohsen.
Yeah, that's a lot.
Great. Fantastic. Good job. So our next speaker is going to be Hagai, and Hagai is going to talk about adolescent scoliosis. And Hagai is one of our outstanding orthopedic spine fellows from Israel. And, I think one of the things, what's interesting for me from, neurosurgical perspective is, in our residency, we don't get involved too much. We know a little bit about the neuromuscular kids because they all get shunts and a lot of, syrinxes and, but it's amazing to me. We treated a lot of kids with really severe deformities it's incredible what and it's so, you literally have to, that is your whole practice, is doing pediatric deformity. It's really incredible. These kids are very difficult to manage. Okay, so Hagai.
Hi, good morning. Yeah, thank you for the introduction, and thank you, Dr. Karami, for the amazing cases. I'm going to talk a little bit about adolescent idiopathic scoliosis, mostly focusing on decision-making around motion preservation and how low to fuse in the lumbar spine. The emphasis will be more on dynamic stabilization options and practical selection of the lowest instrumented vertebra, especially L3 versus L4 in AIS cases. First, I'll go over a quick review of the AIS pattern that drives us to either stop in the thoracic spine or extend the fusion down into the lumbar spine. Some current data on motion preserving strategies, mainly vertebral body tethering and hybrid constructs. And third, an attempt to try and wrap it all up to a practical algorithm, choosing L3 versus L4 as the LIV according to the current literature. Different AIS patterns are dictating different fusion strategies, where lanky 1 and 2 main thoracic curves are the classic selective thoracic fusion candidates. We don't need to extend the fusion down to the lumbar spine. Where lanky 3 and 4 double majors and 5, 6 TL and L curves typically have some structural lumbar components. So distal fusion level becomes a major decision point. In those curves, the question is not whether to fuse the lumbar spine, but where to stop our fusion. Why does it matter? So stopping higher, usually at L3, it preserves more motion segments, which has been associated with better preservation of lumbar function, potentially less degeneration over time. However, stopping too proximally can generate distal adding on and some coronal sagittal imbalance, increasing the risk for the need for revision surgery. So the goal is to select the shortest fusion that still provides durable 3D balance with a low risk for distal progression.
Hagai, go back one slide.
Yeah.
My sort of neurosurgical, I kind of have an elementary perspective on adolescent deformity. But just in general, would you say, I think, regardless of the AIS pattern or type that you have, is that you want to try to stay in the thoracic spine, right? Because if you correct the thoracic spine, then the lumbar compensates.
Yeah,
I think historically, we would do these huge, T2 to L4, and it turns out you don't have to because over time.
Yeah, mostly with the lower lanky grades, 1 and 2, the lumbar curves are usually just compensating for the thoracic curves. And when you fuse or fix the thoracic curves, the lumbar fixes on its own, and you can avoid fusing all the way down.
Can you explain, do we know why? Why does the lumbar correct?
I it's not in this presentation, but usually again that's somewhat why we have this lanky classification where we can see what curves are structural and what curves are rigid, and what corrects in bending X-rays, and what will, as we will predict, will correct after we fix the structural curve with no need for fusion.
I mean, it's interesting because I recently talked to some orthopedic surgeons and neurosurgeons who do adolescents, and their mantra is they only do like T2 to T10 on everyone, and they try to get as much correction as possible. And then they go, we just ignore, we don't want to go into the lumbar spine in these kids because it creates a whole set of new problems down the road. So it's fascinating to me, like I would have never thought that they would say that, you know?
I agree, like we all try to fuse as less as we can, we can. Sometimes with the curves are rigid or structural, and there's some lumbar curves involved that will not fix on their own. If we just fuse the thoracic, then we have no choice but to go down there. The Linkley classification, as we just said, is still the main framework for both categorizing AIS and guiding the fusion level. Where in Linky 1 and 2, where the lumbar curves are flexible and selective thoracic fusion generally safe and allows for the spontaneous lumbar correction. In lumbar modifier C, where the curves are rigid or a clear structural lumbar rigidity and translation, usually it moves us towards non-selective fusion and down into the lumbar spine. That's just what we talked about. For main thoracic curves, most modern algorithms select the distal thoracic level of the stable vertebra or within one level, and we can end the fusion up in the thoracic spine. Getting a horizontal, well-derotated distal thoracic vertebra is important. And for this talk, we'll move to the lumbar level decision, which are more challenging sometimes. Posterior pedicle screw fusion still remains the gold standard for AIS correction due to its predictable 3D correction, low revision rates. Today we have some dynamic options such as vertebral body tethering and some hybrid approaches attempt to correct the deformity while preserving motion, particularly in the lumbar spine where we try to preserve as much motion as we can. Indications remain relatively narrow, are focused on skeletally immature patients with progressive curves despite bracing. VBT, vertebral body tethering, uses compression on the convex side to modulate the growth, gradually correct the deformity as the spine grows. Ideal candidates are skeletally immature, often Sanders under 3 or low Risser with progressive curves, commonly Lanky 1 and 2, again, thoracic curves, despite bracing. Some systematic reviews show a mean reduction of roughly 25 to 30 degrees in major curves at 2 years with preservation of motion, but relatively high complication and revision rates if you compare it to posterior fusion, which is, like I said, still the gold standard. There have been some attempts for a hybrid construct, the combined posterior spinal fusion of the thoracic curves with vertebral body tethering of the lumbar curves in the cases when we need to go down to the lumbar spine, double major or 3C patterns. Some early serious reports, substantial correction of both thoracic and lumbar curves, again with the theoretical advantage of preserving the lumbar motion. The approach carries the same general tether-related risk, like standalone VBT. Indication, long-term durability are still being defined. That's kind of a new concept still. This case series reports the result of 20 patients. They had a follow-up of about a year, and they had good correction and good follow-up on all patients, which is can be an option for some patients. Our issues with distal adding on or revision surgeries, when we get progression of the deformity below the lowest instrumented vertebra, either increased cob angles or deviation from the CSVO. This can result in, again, recurrent trunk shift, shoulder waistline asymmetry, dissatisfaction, and end up in revision surgery and necessitate extension of the fusion. That's why we want to be one and done go all the way that we need, but not too much. Who is at risk for revision or adding on? So again, low low standard stage, more remaining growth. It's a consistent risk factor for distal adding on and continued deterioration of the scoliosis. Stopping the construct proximal to the lowest stable or lowest touch vertebra increases the chance that residual deformity will continue to grow distally. And post-op deviation of the lowest instrumented vertebra from the CSVL, significant distal vertebral tilt are also associated. Again, like mechanically inferior construct are at risk. What are the radiographic criteria in terms of going down to L3 versus L4? In practice, deciding L3 and L4 starts with how well they align with the CSVL. Are they centered? Are they markedly off-center? The preferred LIV is the lowest neutral and stable vertebra with minimal tilt and rotation and good relation to the CSVL. And in skeletally immature patients with significant residual deformity, there's a strong case to choose the lowest stable or touch vertebra as the LIV to limit adding on. As we said, this is a risk factor for revisions. This is a matched cohort data in lanky 5C patients. When radiographic criteria are satisfied, they matched 82 patients. 41 went down to L3 and 41 to L4. And they got the same, when the radiographic criteria was satisfied and they got good correction, they had similar coronal sagittal correction and balance at midterm follow-up. However, stopping at L3 preserves additional motion segment compared to stopping at L4, obviously. And other studies suggest that fusion extending below L3 may offer more immediate coronal control, but can be associated with increased low back pain and disc degeneration over time. So how do we decide L3 versus L4? First, we need to classify the curve and determine the skeletal maturity. In this case, structural lumbar or TL and L curves. If patient is more mature, then he's more tolerant to stopping at L3 and vice versa. On the radiograph, we want to identify the stable and neutral and lowest touch vertebra and see how L3 and L4 are relative to the CSVL. Is L3 at or distal to the neutral vertebra? If not, then we probably need to go down to L4. And the last step is if L3 is nearly bisected by the CSVL, is it minimally tilted? Is it flexible? In a more mature patient, then L3 is the preferred lower instrumented vertebra. If not, or in high-risk patient, like we said before, immature patients, extending to L4 may be the safer option. So just to wrap it up, selecting distal lumbar level is a risk-benefit decision between preserving motion and preventing distal adding on or imbalance. And in appropriately selected TL and L curves, L3 can be reasonable lowest instrumented vertebra, preserving more motion segments, outcomes comparable to L4, and we get the benefits of preserving the motion. Dynamic options like vertebral body tethering on hybrid construct can offer additional tools, particularly in immature patients, but still not ready enough to replace carefully planned posterior fusions. These are some of my references. Thank you.
That was terrific, Hagai. So can you go back a couple slides? I just have a couple questions, and then I don't know if Mark does. Go back a little bit more. So keep going. There was one right there. Again, this is just, we don't have the pre-op images, I know.
Yeah.
But, I think that it's interesting how much this field has evolved. And, the last group of surgeons I talked to, and they're pretty distinguished surgeons, is they go, we don't even care about the numbers. They just literally, like this case, they would try to do as much as they could in terms of, getting as much correction as you can, and they just ignore the lumbar spine. They go, we don't even go. Because what they find is over time, the lumbar corrects. And so that's kind of there. So it's interesting because, we were always taught, go down to the last, vertebral body, and everyone's fixated on, getting the best in terms of numbers. And I think going back to Dubuisset, his principles and, his thinking, I do think that we get sometimes too focused on having the perfect X-ray.
Yeah.
Rather than saying, and I don't know what your thought is on this, Hagai, but I think it's evolving, and I think it's okay to not have a perfect immediate post-op result, because long-term these kids do correct.
Yeah, like I agree with patients, not X-rays, and getting the best X-rays shouldn't be our goal. Getting the best clinical outcome should be our goal. So again, most curves that are more proximal don't need any lumbar fusion, and they will autocorrect once we fix the thoracic part. Some rigid curves in the lumbar spine probably will need some corrections. That's what the current data shows us. But again, perhaps with motion preserving techniques like tethering and maybe neuroconcept, we can try and avoid fusing it, just fixing it slowly with the skeletal growth.
And I do think, again, if you go to your, there's a couple good slides, keep going, is that, again, I mean, let's say you take that one image right there, or the next one, I think with robotics, planning, there's so much stuff that's changing right now. I think it's an exciting time. And I think in the future, I think probably we're going to do shorter fusions with serious correction. And then you can see, I mean, it's amazing what the body does, right? It's almost like it knows it has to correct itself. So, and I don't think people understand. There must be some neuromuscular thing that goes on with your body.
Yeah, I'm sure there is. And I think there's a few, we still don't know what causes AIS to begin with, and there's a bunch of theories, viral theories about infections and even. So yeah, there's so much still to learn and discover.
Mohsen, here you can press the button.
Thank you so much. That was a great talk, especially talking about this slide. So there are many concepts to selective fusion level. So we try to get less fusion in the spine, for sure, as Dr. Skillian mentioned about T10. So there are multiple concepts about that. So you need to, be very updated about the articles. So talking about Lenke or King classification and make your fusion levels according to those, it's not very reasonable. So last time I had because most of the times Lenke type 2 or 6, you have to think about decompensation. Lenke type 2, you're gonna end up to shoulder imbalance, and Lenke type 6, you're gonna cause more issue in terms of selective fusion. But despite having those information, you still have a kind of chance to get to decompensation. So I'm going to mention about go to the next slide. So about this, no, that's not that one. So in terms of lowest fusion level, so we have different terms. So LTV is lowest touch vertebra. So we use it now more than end vertebra or stable vertebra, neutral vertebra. These are different concepts. So probably lowest touch vertebra or LTV is the best thing for now to make your decision for the distal fusion. And then for proximal, parts, most of the time I make it very simple. It's like T2 or T4 most of the time. T2 is like lanky type 2. We do the T2, and then for the other thoracic cases, we can do T4. But the one main issue is like the bottom, of the fusion. So probably LTV is an idea, but to final decision. But if there is, like as you mentioned, lots of rotation of the apex of the lumbar vertebra, and this is a stiff and it's lanky, modifier C. You have to include that.
But see, most of this is the whole point. These guys don't care about that, right? They said, look, we're using all these, for years they went to L3, L4, and they follow these kids and they're miserable when they get older.
Absolutely.
So they're like, we don't care if there's residual curve. And then over time, they've seen that actually it corrects, So
it's
and
very
again,
important.
I obviously am not, you have much more experience, but it's interesting that they would say that.
Yeah.
And that's their mindset now.
Yeah, the
is
thing
try
is-
to get as much correction as they can.
Because pediatric surgeon, they don't follow up the patient out to maturity.
Yeah, they
after
stop
maturity,
after 18. So
and then they
know
send
what
them to
happens.
like adult surgery.
Yeah,
So
exactly.
less fusion, as Dr. Skill mentioned, less, having more mobile segment at the bottom of the fusion is like the most important part, because you're gonna, end up with the long fusion over 2 or 1 segments of mobile segments. So the patient will end up with the, very painful back.
Yeah.
So if you can keep at least 2 levels, it's like ideal situation for the patient.
Cool, great, thanks, Guy.
Thanks so much.
Fantastic. So Oliver is going to be our next speaker. So Oliver is going to talk about, Oliver is one of our fellows from Penn State. And he's going to discuss, so we kind of broke up we did adult deformity, and then obviously surgical management. And then we kind of broke it up to, we're going to do MIS versus open. And so Oliver's going to talk about MIS. And again, just like with, adolescent pediatrics, it's interesting. There's all these different camps, and I just got back from a meeting in New York City, and all the endoscopic guys were there, all the, MIS, and everybody's going crazy with, all sorts of technology and VR, AR, and doing all these, minimally invasive. And it's pretty exciting what's happening right now.
Yes, as Dr. O said, I'm just going to talk about some MIS deformity techniques in a case, and I think Mohammed's going to go after me and talk about more about curves and open deformity. So just quick little background. As we know, adult spinal deformity is highly prevalent in aging population, associated with pain, disability, and reduced quality of life. And the parameters that we all know, that we all learn, sagittal alignment, sagittal vertical axis, pelvic tilt, PIL mismatch, are predictors of outcomes, and we've seen a lot of papers talking about that. The classic and standard way that we've corrected these in the past is with open adult spinal deformity correction. So, doing the maximum invasive, maximal correction. And obviously we know with open techniques, there's just increased risk of morbidities, complications, obviously increased blood loss, transfusions. These patients in the hospital for sometimes weeks. They usually have a few days in the ICU after a big case like this. And obviously there's going to be increased risk of wound infections and other medical complications. So open versus MIS. This is a more MIS style technique, percutaneous instrumentation, smaller incisions, and decreased risk of all those complications. There you go. So why people are considering MIS, this is, people have been doing this for a few years, but why it's becoming more even popular now, there's just this increasing interest in this circumferential MIS deformity correction. So using all of our robotics, navigation, and all of our lateral approaches for things like O-lifts and X-lifts and A-lifts, and using the technology to kind of help us with deformity correction. And theoretically, with these MIS cases, there's decreased blood loss, decreased morbidity compared with open surgery. Just kind of makes sense. Smaller incisions, minimally invasive. It should lead to all those decrease in complications. Obviously, not doing the midline approach, you're trying to do muscle sparing and preserving that posterior tension band that we talk about with the ligaments and keeping that intact. And with these MIS techniques for deformity correction, typically patients have shorter hospital stays and then just faster recovery in general because, smaller incisions and all those things. So I think the key is, every talk you hear about MIS deformity, it's all about patient selection, and that's the most important thing. For people to have success or patients to have success with MIS deformity, they really just need it's a mild or moderate deformity. People typically quote out 30 to 40 degrees on the coronal plane. They need to have flexible curves on dynamic imaging, and this makes sense. With MIS deformity, you're typically not doing your big bony PSO where you can do massive corrections, so they need flexible curves. They need an SVA that's typically less than 6 to 8 centimeters. Patients that have really long SVAs or high SVAs, you're not going to be able to get that correction just from MIS deformity techniques using cages and instrumentation. Typically, you're going to need to do more of an open kind of bony PSO, things like that. And they need to have good bone quality because you're really going to try and, with that flexible curve and with that bone quality, you're going to try and correct the curves in MIS. So I think the key really to MIS is just having a good patient selection, a good surgical strategy, and that'll lead to a good outcome. But the key really is in that patient selection to have these patients do well and succeed. So these are some of the core techniques in MIS. I'm not going to go through all these. Each of these in themselves could be a talk on its own, but things like the X-lift, lateral interbody fusion, O-lift, the oblique lumbar interbody fusion, A-lift, anterior lumbar interbody fusion, or an MIS T-lift, all different techniques of trying to get anterior column support and fusion. And then obviously one of the big techniques of MIS is percutaneous pedicle screw instrumentation, which I kind of showed in that picture earlier. So especially things like, now that we have all this navigation, robotics, and it's becoming better and better and more efficient, these techniques become a lot, maybe quote, simpler to do. So for the anterior lateral approaches, the role of these is really just for coronal plane correction. Obviously, putting a big cage in a collapsed disc space is going to lead to indirect neural decompression because you're restoring disc height and opening up those foramen. You're improving segmental lordosis, and really using these anterolateral approaches is the foundation for MIS strategies because you're not able to do, the big kind of posterolateral fusions that you do in an open procedure. I just wanted to quickly go into this MISD-F2, MISD-F2 algorithm. This was published in JNS. It's a pretty highly cited and quoted paper in the MIS deformity realm. But it's a paper done by a lot of really great spine surgeons, basically trying to guide how invasive you need to be for a patient with adult spinal deformity. And it basically matches up a patient's radiographic severity and what type of procedure you need to do for them. And it really emphasized sagittal alignment as a driver of outcomes. And this, they have a pretty nice kind of flow chart in there, but this is just going over quickly. So they have different classes, 1 through 4. They talk about the differences in their in patient deformity and alignment. So if it's just kind of a mild coronal curve focal pathology with a normal SVA, you can really just do an MIS decompression and fusion. And that goes all the way up to a severe and fixed deformity with a really high sagittal imbalance and increased SVA. And that's when you really need to do the open deformity correction osteotomies. And I think the flow chart that they have, I think, is extremely helpful of kind of how to think about these things. And obviously this isn't a law, but I think it just kind of helps frame the discussion and frame how we think about these things. And I think it kind of helps us as spine surgeons to kind of decide where to take a patient. So this is their kind of algorithm, and I'm really just kind of, maybe I'll go over just class 1. So, again, initially you want to look at a fused, if it's a fused or rigid spine or not. That's the biggest thing in the beginning. And if it's not fused and not rigid spine and it moves on dynamic imaging, you can kind of start going in that MIS realm. Lower SVA, a lower pelvic tilt, so meaning they have less compensation, and LLPI mismatch less than 10 degrees, coronal cob angle less than 20. This is the class 1, kind of a simple case. You can do an MIS surgery. small fusion, decompression, and this goes all the way up to class 4. And I think, again, this is just a nice way to frame the discussion and frame your thought process when thinking about MS deformity. So limitations, I think, and this is a big one, you're never going to be able to get as much of a curve correction, just doing a lateral cage as you would doing a posterior PSO or VCR, even, all these things. It can't really happen. Even with hyperlordotic cages and these things, it just doesn't happen. So you can't correct severe deformity patients. And I think in the beginning, these MS techniques, really it's just a steeper learning curve because you really rely more on technology versus just doing an open posterior. And with doing, percutaneous and doing lateral approaches, anterior approaches, the complication profile changes. So as we know with these approaches, there's just a higher risk of lumbar plexus injury and injury to all the vascular structures because obviously we're going through the plexus or we're going around the iliacs. And so there's just, you're working in that area. There's an increased risk that you're going to hurt those structures. Obviously risk to visceral structures, you're going past bowel, et cetera. And really, these MIS techniques, you just can't use them in patients with severe PIL mismatch or a very, large SVA. I think the future directions, and this is kind of already going there, is just our robotic surgery is getting better and better and better. It's quicker, it's more efficient. And I think using that is going to help MIS. And then obviously with a lot of these companies, they're starting to have these patient-specific rods, and I think that's helpful, and those templates are helpful for correction in an MIS way. This was just a quick case that of Dr. Skudian's, actually, the patient that was just having progressive back pain, this coronal scoliotic curve that was obviously resistant to conservative measures. And, this curve, it looks pretty substantial, but even with this, using these MIS approaches, using lateral cages and then percutaneous screw instrumentation, you're able to get a really good correction. So, I think it takes some time. It's a learning curve and takes some practice, but, as long as you have a good patient selection, these patients can be corrected well with an MS technique.
That was great, Oliver. So go back a couple slides. I think when I think of MIS and keep going back to that algorithm, I think I got, I think these algorithms are okay, but I think for me, so much, if you're going to do quote unquote MIS surgery for deformity, first of all, I think you have to get a good correction, a good result, right? And then the second thing is, it has to fuse. And then the third thing is, again, this is just my experience doing MIS. You have 25 stab incisions. Is that really better than just one midline incision? So, people kind of throw out all these things. And again, these algorithms that, we create, and as surgeons, we try to classify everything and then make it structured. For me, the workhorse of adult deformity is getting the correction, especially in the lumbosacral junction. And that, to me, is best done anteriorly. There's nothing better than doing an ALIF 1 or 2 levels. And, you don't cut any muscle. You have a good access surgeon. You can get a lot of correction. And you get to fuse. So I've kind of, again, just like the previous, I think this whole area is evolving. And I think with the instrumentation, all the cages are better. We can release the spine anteriorly. I'm doing a lot of standalone, anterior 1 or 2 levels, and then just staging these, and then, bringing the patient back, 6 weeks later. And again, there's a lot of people doing prone, posterior, this area is rapidly evolving because of technology and the hardware that is, available to surgeons.
Yeah, I agree. I think that's a great point. And I think with these anterior approaches, you're able to stage, which is great. You can, if you're trying to get some sort of sagittal correction, you can do that anterior approach, and then you can do that one day, stand them up, get an X-ray, see how their correction, how far you've progressed with the anterior approach, and then be able to adjust it and just your posterior plan based
Yeah.
on that. You may not need to do a big bony, reconstruction in the back if your cage gave you more, sagittal correction than you thought.
Yeah.
So I think staging.
And even like yesterday, we did 2 A-lifts. We, got 15, 20 degrees per level, and really released it. So you can do a lot anteriorly. I think that's kind of for me, that's the workhorse.
Agreed.
So great. Thanks, Oliver.
Yep.
Great. So our next speaker is Dr. Mohammed El-Hushaimi, who is going to talk about
maximally invasive
adult
anti-MIS.
adult deformity and some MIS. So
Thank you all for being here. Good morning again. So I'm gonna talk about adult spinal deformity. I'm gonna mostly delve into the classification system and how the historical evolution of these classifications has been there. I will start my presentation with a failed MIS case and see what's your suggestions, and then we'll go mostly a brief review about the classification and a brief talk. You cannot talk about adult deformity without talking about the osteotomies. So that will be it. So beginning with this case, this is a 71-year-old female. She has a long history of neglected adolescent idiopathic scoliosis. She presented to clinic with back pain, leg pain, and difficulty walking, the typical presentation. She has been through an extensive non-operative care program. Surprisingly, her husband is a biomechanical engineer and also a spine researcher. She's a depression, hypertension, and other comorbidities. Her past medical surgical history included an 5-1 ALIF, and we'll show later on the X-ray, and 2-level ACDF. These are the non-operative treatment options. Patient tried to modify her activities, physical therapy, regular stuff, with no improvement. On physical exam, she was grossly fine. She had some little bit of sensory dysfunction, lower extremities. Otherwise, motor, she was fine, reflexes fine. This is her X-ray. So as you know, this is the sagittal image. The patient is sagittally balanced, but most of the deformity is in the coronal plane. As you note here, this 5-1 ALIF failed to correct this fractional curve at the lower lumbar spine. She has this pretty large thoracolumbar curve with an apex at L2. This is her pre-op MRI. Focal levels of mild to moderate stenosis, mostly at L3, L4, and there was significant rotational deformity and multiple dysplastic pedicles here on the concavity. As part of the workup, also a myelogram was done, and this is what we ended with. So we have, as I mentioned, this rotational deformity, and here we appreciate the significant dysplastic pedicles and the rotation of the spine.
how about 5-1? Was 5-1 fused? Not?
She has the ALIF 5-1.
Right,
It
but did it
appeared to be
fuse?
fused, yeah,
It is fused.
yeah.
Okay.
So this is what 71 secondary. This is considered a secondary scoliotic deformity due to if a neglected adolescent scoliosis considered lanky type 6C. We'll delve later into the classification. What are your thoughts? What do you think? Should we go again MIS? Should we open her up?
These are tough cases. Mark, I don't know what your thought is, but
Yeah, I'll be totally honest. If I saw this patient in my clinic, I'm looking at her balance. She's a little pitched forward on the sagittal plane. SVAs, I'm sure positive,
Within 5, so
Yeah.
it's not.
not severe. And her coronal plane actually looks fairly balanced despite the fractional curve and that kind of upper lumbar thoracic curve. So, at least from my perspective, at 71 years old, she seems like she's actually fairly well balanced despite the curve. And, it looks like she's got some foraminal stenosis and a couple of areas of some central stenosis along the canal, which, frankly, are hard to address alone. So, this is someone that I would put through a really intensive course of conservative management first. And I learned this from Dr. Chapman, Dr. Escuyan, send these patients to the swimming pool. It's a great place for them to rehab. Reduces the effective gravity on their body. They can move more freely. Get them set up with Schroth method, physical therapists, and really focus on. And although she's 71 years old, she's not going to be quite as flexible as someone younger. But I think at least a really solid attempt at these things and demonstrating failure of these strategies should be at least well documented before we engage in discussions of a big fusion. But
And her alignment's not that bad. I mean, look, she's balanced, right?
Yeah.
I mean, I'm going to take the conservative approach. She's got, if you look on the sagittal, it's not terrible. And then coronal's not bad. I mean, my clinic is full of these cases, and her bone
She
quality
tried all
doesn't look.
these non-operative stuff, PT.
Yeah.
She's still in severe misery,
Yeah.
severe pain.
Again, I mean, we see a lot of these cases, and I think adult deformity is extremely challenging.
Definitely.
My initial thought, when I meet these folks, is I sometimes mention that sometimes the treatment's worse than the disease. It depends on obviously how bad their symptoms are, and again, if they've put an honest effort into all these things and they're still really struggling. To be honest, I wait till they really kind of beg for the operation, just because I sometimes feel like we jump to the gun with surgery too soon, and it doesn't lead to the results that they want. So, but once you've gotten to that point, you've established a good relationship with the patient, you've demonstrated that they've put an honest effort into these things, then we start talking about reconstructive strategies. And in her case, you're unfortunately probably going to have to end up going T10 all the way down to the pelvis to get the correction you want. I think going any shorter, you're going to probably pitch her in the wrong direction and make things worse probably. But extending across that thoracolumbar junction is going to be needed in this case to get the correction.
Thank you so much. I totally agree. The patient, the relationship with the patient is the most important thing. The patient expectation should be set. This is the first thing. This is the different thing when we're looking adult versus adolescent versus pediatric. The patient's expectations of how well he will do after surgery will be the most challenging part to address. She should be aware of that, and this should be taken very seriously when choosing these patients. So as Dr. Mark mentioned, we went through all these non-operative stuff, and finally the patient wanted to pursue the surgical route, and this is what we ended up with. So we did a T8 to pelvis, T9 to pelvis with hooks at T8. We did 4-level IDOs, eccentric IDOs starting down at the right 4-5, and here on the left side on the upper level. And this is the pretty good correction that we ended up with. Our CT scan post-op was also very nicely reconstructed and very well reassured patient is very happy for the outcome. We'll see how she does. She's 1 week out of the procedure, doing fine, and we'll hope for her for the best. As I mentioned, ASD, it's defined as deformity in skeletally mature, this is the important term, with a coronal cup angle more than 10 degrees. It includes all these scoliosis, kyphosis, flat back, combined kyphoscoliosis. The prevalence of deformity in adults is reported between 2 to 32%. In the previous reports, although in the current aging population, a recent paper reported prevalence up to 60%. With the increase in longevity globally, the number of adult patient deformity is increasing and is higher than that of the adolescent patients. These are the factors that should guide the treatment, and as I mentioned here, the expectations should be set early: symptomatology, disability, patient general health, the age, the bone quality is the most important, and lastly, the expectations of the patient. And he should be aware about the morbidity of such surgeries. These are surgeries with a lot of blood loss, as Oliver mentioned, ICU, and all these stuff. Going into the classifications, as I mentioned, why we like to classify these scoliosis, it guides our treatment surgical decision. You cannot show one case for, you can show a case for 10 spine surgeons and you can get 10 different answers. So this is the aim of classifying, standardizing the techniques, standardizing the reporting of the outcomes, and also improving the health-related quality of life. The early etiologic classification started with, as Mohsen and previously Hagai and Oliver mentioned, adult idiopathic scoliosis, which is a progressed AIS, de novo degenerative scoliosis. We call it the discogenic curve due to the asymmetric degeneration leading to these deformities, and secondary scoliosis due to other pathophysiologies, neuromuscular, metabolic disorders. The earliest classifications was the King classification that Hagai already mentioned. King and Mo 1983 was the first to describe these curves, type 1 to type 5. This was mostly like did not rely mostly on the coronal deformity. They did not mention the rotational, the third aspect of all these deformities, which is the most importantly, the rotational aspect. King, as I mentioned, classified into 5 types. This is the first type, an S-shaped curve, mostly double curve in which both thoracic and lumbar cross the midline. You see, it's very visual, very nice, but as I mentioned, did not mention the rotational aspect of the deformity. And the nice thing about it that it gives some treatment recommendations. So for this type, the recommended type was like thoracic fusion down to L1 only, as Dr. Skunin mentioned. So in this classification, they tried to guide our treatment. The other types, I will not go into the specific details of this. So these are the 5 types of the King's classification. Later on, in 2001, Simons suggested 2 types of deformity. Here, the concept of rotational deformity started to appear. So type 1, degenerative lumbar scoliosis with no or minimal rotational deformity, looking at the axial images. Type 2, degenerative scoliosis often superimposed on pre-existing scoliosis with greater regional deformity and greater loss of lordosis. carrying on a lot of classification, AB, max AB, 2005. Again, three types of classification. Type 1, primarily degenerative. Type 2, progressive idiopathic, secondary scoliosis. Also, all of these details we don't have to go into. This is just a historical overview, reaching to the latest one, the Lenke classification. 2005, the famous Frank Schwab proposed a radiographic classification system based on two important parameters: the degree of lordosis from L1 to S1, frontal plane obliquity at L3 on standing radiographs. So this is his classification. He classified it into three types: lumbar lordosis more than 55 with L3 obliquity less than 15 degrees, type 1, and up to type 3, where the lumbar lordosis is reduced below 35 and the obliquity of L3 up to 25 degrees. Schwab continued on updating his classifications until we got this Schwab classification, the SRS classification, and in these times the sagittal modifier came into view. At that period, the pelvic parameters started to appear, and these famous three recommendations were the sagittal modifiers included, which were the PI minus lumbar lordosis that should be within 10 degrees, the global alignment, the SVA, should be between 0 and 5, and the pelvic tilt that should be less than 20 degrees. Ending with this Lenke adult spinal classification, so AISD 2021, Lenke modified his adolescent scoliosis classification to include the sagittal modifiers. So the curve types were mostly 6 types, 1 to 6. The lumbar modifiers A, B, and C, I will show them later on. And the sagittal will be either negative, neutral, or positive, depending on the degree of scoliosis. An example of Lenke will be a type 2 curve with a lumbar modifier A and a hypokyphotic curve, and that would be 2A minus. The good thing about this classification, it's like a more comprehensive classification. It includes mostly all the types, two-dimensional, as I mentioned, not only the coronal deformity, but also it includes the sagittal, treatment-based, reliable. It has been actually tested for both inter and intra-observer reproducibility. The objective specific criteria that are clearly understood and can be applied. So the most important thing when trying to classify these patients is to get the perfect 36-inch X-ray, upright coronal, upright sagittal, the concept of bending curves, the left supine bending and the right supine bending. In some cases, we can rely on the supine bending films, that the scout images that we can see on MRI or the CT scan, where the patient is lying. We take the effect of gravity and we see how flexible these curves are. The determination of the curve types, it depends on the region. The spine is divided into 3 basic regions: a proximal thoracic T1 to T3, a main thoracic T6 down to T11-12, the apex between T6 and 11-12, the thoracolumbar and the thoracolumbar. These are in the same category. The determination of the curve type, we always hear about major and minor curves. So the major curve criteria will be the one with the largest cup angle. By definition, we can have 2 majors or 1 major, 1 minor curve, or we can have a triple major curve depending on the classification. The structural criteria as per Lenke, just quickly, for each type, they included the structural criteria. For example, for a minor proximal thoracic curve, there should be residual coronal curve greater than or equal to 25 degrees on supine bending films. And a separate criteria will be a kyphosis 2 to 5, T2 to T5 greater than or equal to 20, regardless of the flexibility. So one of these criteria can determine whether a curve is structural or not. And he included for the other curves, for the main thoracic and for the thoracolumbar curve. For the lumbar modifiers, the lumbar modifier is determined by drawing a line, a vertical line straight from the sacrum up, the CSVL. Looking at the lumbar vertebra, we determine the apex of the apex of the curve, and a lumbar modifier A designed if this line lies between these two pedicles. This is type A. Type B, where the line passes through one of the pedicles, and the most severe will be type C, where this vertical line lies above the apex of this outside the pedicles of the apical vertebra here, and does not touch any of these two pedicles. Finally, for the sagittal modifiers, so as I included earlier, so we have three types. The negative sagittal modifier, where we have hypokyphosis less than 10 degrees, thoracic kyphosis, the normal kyphotic measurement between 10 to 40 degrees, designated as N or normokyphosis, and the hyperkyphotic will be where we have thoracic kyphosis more than 40 degrees. This is summarized the classification system of Lenke based on all the criteria I previously mentioned. This is very visual, but you need some time to get into the structural criteria and be able to determine how we know the modifiers A, B, and C depending. So we should go step by step over that, what I mentioned earlier, and it will be easier to get into the curve type. We'll end with parameters. Oliver brought those parameters into attention, the most important PI, the incident, which is the fixed parameter throughout adulthood, the pelvic tilt, and the SVA. I will not go further detail. We should keep in mind these radiologic goals. SVA within 5 centimeter, PI lumbar dorsal mismatch should be less than 10 degrees, PT less than 20 degrees. Although these parameters and goals are sometimes not logical, knowing that the patient, most of these patients are elderly, and a lot of these patients have a lot of the complications. We'll end with the osteotomies. You cannot talk, as I mentioned, about adult deformity without mentioning the osteotomies. These are the 6 levels of osteotomies classified by Schwab, from a simple partial facetectomy to a complete multiple level vertebral disc vertebrectomies. And these are some numbers to keep in mind. So for a type 2 osteotomy, a Smith-Peterson or a Ponti, you can get 10 degrees per level of correction. For a PSO, you can get up to 30 degrees of correction per level. And for a VCR, you can get up to 60 degrees, 40 to 60 degrees of correction. This is a very nice algorithm suggested by Schwab on how and when to use each of these osteotomies. So to begin with, you should be experienced to do this osteotomy. So this was the first question, yes, no. And going into this medical condition of the patient, gradual or sharp kyphosis, kyphotic deformity, we should assess the disc, how mobile are the discs. If these discs are very rigid and fixed, we can go to a higher level a PSO, VCR. If these discs are mobile, mostly in adolescence, so an SPO or a Ponte osteotomy will be nearly enough to help with this correction. Will not go into all this stuff. The limitation of current systems to end with, all these systems, they do not include age-adjusted alignment parameters. These should be our future goals, mostly in research. They do not include specific comorbidities. And as I mentioned, high complication rates for these, but in severe cases of deformity, still the MIS did not reach the level to achieve the needed correction. So that's why we're still requiring these open surgeries. So age-adjusted alignment targets, risk stratification for the patient, and treatment-oriented categories. And this is my reference. Thank you so much.
Well, thank you, Mohammed. I think that, you know, there's been a well-published, you know, huge need for, you know, care for these spinal deformities, especially with an aging population. We're seeing more and more of these. And, you know, we have a powerful tool in our pocket with, you know, not only these new MIS strategies to sometimes, you know, correct these things, but of course the age-tested, you know, big osteotomies that you described at the end to fix these things. You know, at the end of the day, you know, patient selection is key. And this is one of those situations where I'm sure every deformity surgeon has their own criteria and different things that they look for. And this is really what comes, this is really where the art of spinal deformity comes from. And, you know, at the end of the day, you know, when you decide to take the leap and you know, perform these operations, and they can be hugely life-altering and hugely beneficial for patients, you just have to have a really well-documented and well-thought-out strategy to perform the operation. All these classification schemes, they do a really nice job of helping you think about different things you should, you know, consider. And at the end of the day, you know, looking through the imaging, whether it's a myelogram, which is commonly the algorithm that we use here to both give us a good 3D bony anatomy, but also idea of where the neuro elements are, and understanding what that imaging is telling you and where you're going to be able to get your correction. And, you know, I think that's absolutely paramount. So these are among the all cases that we do should be extremely well thought out, but these probably are probably at the precipice, the top, I would say, of the totem pole in terms of the amount of effort that needs to be done in terms of preparation and strategy. So I think this is a nice talk that kind of incorporates a lot of those different elements and kind of a nice starting point for folks to use as a tool to start designing these cases. So thank you.
Thank you.
So I think we can end probably a little early. Everyone ran off to the ORs already. And lastly, I'll mention that we have our trauma summit tomorrow. Or sorry, not tomorrow, Friday, Saturday, the 19th and 20th. Put a plug in for that. So thank you again for tuning in, and I look forward to having you back sometime soon.